and welcome to this session, which we hope will be of great value to yourselves and to also those who attend and the presenters. My name is Stephen Muhudia. I'm a pediatrician, a member of Kenya Paediatric Association, and I'll be chairing this session. But as you know, this is the Kenya Paediatric Association. The overall theme is from data to practice. And this is a workshop that is at that end at the practice level. So this fits very well with the theme or the overall theme of the Kenya Paediatric Association conference today, which is data from data to practice. And it further says that harnessing technology to optimize healthcare from the neonate to the adolescent. Again, we are on the beginning end of this particular spectrum in the neonate, in the infant, and how to bring the best of this. So the topic of this particular workshop is LactaHub workshop, lactation management workshop, and it will be conducted by the Kenya Association of Breastfeeding.
Thank you for taking the time to come in for our workshop. We hope it's going to be an interactive one. So to start us off, we'll just go through an overview of what we know as the Global Health Association when it comes to breastfeeding. And can do the slides. Next slide. All right. So I'm sure all of you are familiar with this slide about benefits of breastfeeding. There are benefits both to the mother and the baby. And like we said, as a global health community, this has come to be common knowledge, which we are now trying to put into practice and to increase the uptake of breastfeeding amongst the moms that we support. So as you can see, if we start with benefits of breastfeeding for babies, you have a lot of immunological benefits. Breast milk has been shown to be protective for the newborn. It helps with their development. So this is through nutrition. It helps with their growth and development. And it helps to protect them against long-term chronic illnesses. And we'll delve into the details of how that happens. So it provides complete nutrients. We are going to go through a few of the important nutrients that we'll highlight. Easily digested, readily available, protects against infection and long-term non-communicable diseases such as diabetes, hypertension, which is becoming a problem with our generation. We are seeing a lot of the non-communicable diseases coming up with the younger children and adolescents. It is cost-friendly in comparison to artificial feeding. Again, we have all encountered how expensive formula feeds have become in the recent economy. Less allergy and milk intolerance associated with human breast milk, and readily available at an optimal temperature. So if we delve into the benefits of breastfeeding for the moms, immediate benefits, it helps in the immediate postpartum period with the healing and recovery from bleeding. You have contraction of the uterus, which protects the mom from postpartum hemorrhage. And then you have less risk of postpartum depression. You have increased bonding, increased self-esteem, weight control for the mom. Saves time and money. We've said this is readily available, optimum temperature, cost-effective for the mom. And then reduces the risk of sudden infant death syndrome. Promotes proper jaw, teeth, and speech development for the baby. I think Esther will take us through the breastfeeding, sucking, and swallowing reflex and how that develops in the newborn. Reduces malnutrition and vitamin A deficiency, as we'll talk about the nutrients available in the breast milk. Reduces time lost from work to care for a sick baby. We have highlighted the protective components of breast milk for the baby. So you have less sick days where you have to take care of a sick baby. It's comforting for the baby, especially when they're fussy, when they're tired, post-vaccination, when they're ill. This is a very soothing session for the baby and promotes a healthier population. Next slide, please. So let's look at the superiority of breast milk in comparison to man-made formula. There are lots of similarities, and these formulas are marketed as being an optimum substitute to breast milk, but if we are being honest, there is no replacing breast milk. It has a myriad of molecular and cellular components which are not, you're not able to replicate some of this. When we talk about the nutrients available in breast milk, we talk about things like antibodies, which are pretty high, especially in colostrum. This is the initial milk that you get the first stages post-delivery. Very high in protein, and majority of that protein being the immune globulins, secretory immune globulins, which provide immunity to the baby and also help with the development of the gut and the immune system. And then you also have things like hormones, antiviruses, growth factors, and enzymes, which as much as we try cannot be replicated in the infant formula. So there's a big debate about comparison of human breast milk to bovine milk. So cow's milk, goat's milk, camel's milk, and all the other mammalian milks that I'm sure most of us have encountered. So the big debate starts a lot with the composition of the different milks. And as you can see, the main one that we're going to cover is the proportion of protein in the human milk vis-a-vis the bovine milk. There's a larger component of protein in the cow's and goat's milk, and we'll delve into details about the specifics of the proteins in comparison to the human milk. So on the next slide, to be specific, you have two types of protein, both in cow's milk and in human milk. You have casein and whey. You can look at those proportions. You have a larger proportion of casein in the bovine milk in comparison to the human milk. The reason this is important is that the smaller percentage of casein in human milk, casein is not fully digested. It is partially digested by an enzyme in the breast ducts and in the baby's stomach. Partially digested, and then it's precipitated to what we call curds. And the curds are now eliminated in the baby's stomach. So the larger proportion of casein in the human milk allows for easier digestion and elimination of these softer curds in the baby's milk. In comparison to the larger proportion, you can see we have 35% of casein in human milk in comparison to about 80% in the cow's milk. So because of the larger proportion of casein in the cow's milk, you form harder curds, which are a bit difficult for the baby to digest and eliminate from the stomach. So this is, again, one of the big discussions, why we have a lot of babies who get cow's milk intolerance, and why we do not consider it a favorable alternative to human breast milk. And then the other one, we talked about whey. It has a lot of anti-infective proteins. Whey is a larger protein, the larger proportion of protein in human milk. So it has immunoglobulins, it has lactoferrin. Lactoferrin binds to the iron and helps in the absorption of iron in human milk, and that feature is not replicated in the bovine milk. The lactoferrin is not able to bind to the iron. So for babies who are fed on bovine milk, you find you have a risk of iron deficiency. And then you have also a lot of secretory IgA, which is available in the whey protein. So again, this goes to the providing immunity for the baby on human milk and also helping with the development of the immune system. So we've talked about the different types of breast milk. We've talked about colostrum. I'm sure most of you have heard about it. Liquid gold, and mainly because we've said it's higher in the amount of protein and immunoglobulins. It's available the first 3 to 4 days after delivery. In some cases, you have moms who start lactation pre-delivery. So the initial milk is colostrum, very high in protein and calories, and rich in antibodies. So this is again why you want to initiate breastfeeding pretty early on after delivery. Ideally, the recommendation is within the first hour post-delivery, and you want to encourage this the next 2-3 days so that the babies are able to get the full benefits of the colostrum. Then following days, 4 to 10 days, the first week post-delivery, you have what we call transitional milk. Less protein in comparison to the colostrum. And then now from the second week, you start having mature milk, which we'll go into detail about fore milk and hind milk and why this is important for the baby's growth. All right, so there is a visual representation of what we've talked about, and you can see the different compositions and the colors. So the colostrum, it's liquid gold, very high in protein, tends to be very deep yellow, as you can see from the first picture. And then we compare now the mature milk. You have foremilk and hindmilk. And again, this will come into practicality when Esther takes us through breastfeeding and lactation, and the questions we get from moms: how do I know the baby is getting enough? My baby is breastfeeding frequently but is not gaining weight. What could be the problem? So these are some of the areas that we are going to address. So for milk, when it comes to the mature milk, you have for milk, which is rich in water in comparison to the fats and calories. This is beneficial for the baby's hydration. So again, it comes to the question of, is breast milk really enough to hydrate the baby for 6 months? So this answers your question. You have about 80 to 88% of breast milk being water, and a lot of it will be in your foremilk. Hind milk, as you can see, it's a lot thicker, creamier, yellow, rich in fat and calories. This is what helps the baby to grow and put on the weight. So when we're advising our moms, this is something important. Don't change from one breast to the other too fast, because as the breastfeeding continues, you have an increase in the fat content of the milk, and the calories also go up with the hind milk. Again, this is a visual representation of the capacity of the baby's stomach. It's important to know this because, again, the question that we get from new moms is, I don't think I have enough milk. My baby's not getting enough. I think the baby is hungry. So it's important to have this visual representation of a baby's stomach from day one and then proceeding on to the weeks after birth. So day one, you have a small size, about the size of a cherry, 5 to 7 mLs. So again, colostrum is very thick, minimal amount, so you do not need a large amount of it. So when moms are saying, I don't have enough milk, my baby has not breastfed enough, you can encourage them with a visual representation. For the baby's stomach is pretty small, the first day of life. They just need a small feed, but you need to feed them frequently. As the stomach capacity increases by day 3, you can see we move to about 20 to 30 mLs. So you want to encourage the moms to feed, even though they're small feeds, but they want to do it frequently. So the baby should be on the breast as frequently as possible. And this will delve into what we call rooming in, mom and baby staying together immediately after delivery, just to allow for this increased or frequent feeding for increased milk production. By week 1, you have about a stomach capacity of 45 to 60 mLs, and that gradually increases. By the time the baby is 1 month, you have a capacity of up to 80 to 150 mLs. So gradually the capacity increases, and this will be achieved by frequent feeding or feeding on demand. So again, when you're advising the moms, you want to advise them, babies should not go for prolonged periods without feeds so that you can establish this kind of capacities. And then we'll look at the anatomy of the breast, of the organ. So you have various components of the breast. So we'll start with the alveoli or the lobules. Sorry, I don't have a pointer. But basically, when it comes to the development of the breast, you have the lobules and the ducts. You have clusters of lobules, as you can see. There's little clusters here. So multiple lobules in there, and that's where you have the milk secretion or the milk production. And then you have the epithelial milk secreting cells. So that's the basic component of the lobules. And then around them, they're surrounded by myoepithelial cells. And when we look at the hormones that assist in breastfeeding, we'll see how they come into play. So you have the lobules, which now drain into the milk duct, and then the milk is pushed into the lactiferous sinuses and out in the nipple. So this is just a visual representation of where the milk comes in, and then I think in the next slide we'll talk about the hormones that affect lactation and breastfeeding. So the physiology of it, we know about the reproductive hormones. During pregnancy, you have estrogen, progesterone, other metabolic hormones, growth factors, which help in the development of the breast. But when it comes to milk production and lactation, initiating lactation and sustaining lactation, you have 2 primary hormones that come into play. you have prolactin and oxytocin. So milk letdown is predominantly a tactile sensation or reflex where you have the baby latching on to the breast, and then you get a stimulus sent up to the brain. Then the brain, through the hypothalamus and posterior pituitary, produces oxytocin and prolactin from the anterior pituitary. So the prolactin hormone is what helps with the milk production. And then the oxytocin is what helps with the milk letdown. So what we were talking about is you have the milk secreting cells in the lobules, and then you have the myoepithelial cells, which are more muscular. So you have milk production from the lactiferous cells, and then you have oxytocin helping the myoepithelial cells contract to now release the milk into the ducts and out through the nipple. So this kind of reflex, it is affected by various things. So one, we said it's a reflex that will be triggered by suckling stimulus, so latching the baby on the breast. And also it will be triggered in some cases by mom thinking about the baby. There are various things that will trigger the brain reflex. Similarly, the way it is triggered, it can also be affected by certain things such as stress, pain, illnesses. So this is something to keep in mind again when we are supporting the moms, is what could be affecting her milk letdown, what could be affecting this reflex. And there are the stresses that we know about, illnesses, wars, pain, but there are also some which are undermined, is a physiological stress for the mom, where she feels she doesn't have enough milk for her baby, where she feels she's not doing a good job in terms of breastfeeding her baby. So we also need to think about the psychological stress that the mom is going through, and this is where the support for the breastfeeding mom comes in. So we've gone through the stages of lactation. We've talked about the different kinds of milk that you get. This is what we're talking about, the mammogenesis, mammary gland development, which happens usually from about 3 to 4 weeks gestation, supported by the hormones we talked about. And then you have lactogenesis, which is the initial phase of milk production, starts from the prenatal weeks of 16 up to 72 hours postpartum, and this is where you get a lot of the colostrum production beginning. Then milk production or lactogenesis, where you now have the mature milk coming in between 30 to 72 hours postpartum, and we've talked about the changes in milk volume and composition. And then now maintenance of the lactation and milk secretion that goes on until the end of breastfeeding. All right, so I'd like to invite my colleague Esther to take you through the second part.
Thank you for that. And so, now we want to get more to the practical part of breastfeeding. And when we talk about attachment, latching, attachment, what does it actually mean? We generally know what a poor latch is, a bad latch, a good latch. And in some of the language that we use when dealing with mothers, it's important for us to even look at it. Because if I am observing a mother and I'm saying you have a bad latch, as an adult, what do you think that tells us? If I come and tell you I have a bad latch, what do you as a mother feel?
It's like I don't know what I'm supposed to be doing.
What do you think that does to the confidence of the mother? It just goes down, isn't it? So that mother already thinks, I have had this baby, I don't know what I'm doing. So part of lactation management is us changing the way the language is. If I come and I'm looking at a mother and I'm saying, I want to see how you're breastfeeding. Yeah? As an adult, what do you feel when someone is watching you? You're already on the defensive, isn't it? So even when I come to a mom, I would just say, I want to see how the baby is feeding. Because now I have put like the pressure on the baby, And because the baby doesn't understand, the mother already feels, okay, now I can show you how the baby is feeding. So those are some of the little components of how we support our mothers so that we are actually able to see and they're actually able to be open to us so that we can support them. So when we look at the attachment at the breast, the first picture, what are the components that you can see? What's in the first picture? Where is the baby's mouth? Around the areola, yeah? Where is the chin? It's pressed against the breast, isn't it? And when you look at that picture, you can see that the baby is able to compress. What Dr. was talking about is able to compress. When we look at the breast anatomy, is able to compress the milk and out. Look on this other picture. Can you see where the milk is? The baby's mouth is actually on the nipple, and what it's doing, it's actually blocking. It's almost like taking milk from a nipple, or from, if you're taking some water from a straw that's squeezed. Will you be able to remove the milk? So that's what's happening to that picture. And you can see, visually, this is what you'll see. The chin, I wish we had a pointer. The chin is far away from the breast. The baby is looking, when you look at it visually, the baby you'd be seeing dimpling. For this other baby, you're hearing lots of sound. You know, you'll be seeing the baby really struggling, fussing at the breast. And those are the visuals that we see. So we want to talk a little more about how does this attachment happen. And then, see, so next slide. So, when we look at this baby, I have a baby here. Thank you. I have a baby here. So this baby is right, and the visual that most of us see, first of all, is a lot of times we tell them tummy to tummy, isn't it? We are very, very good at saying that, tummy to tummy. So tummy to tummy works for some of us who are very short, where my tummy, if I sit down, my tummy and the baby are right there. But what happens to taller moms who are tall like Kai? We have moms like those. So the tummy is right here. Can you see his torso? So his tummy is right here. And then I've told the mother, put your tummy and the baby on the tummy. And so what happens? The mother is trying to follow. They're very obedient. They're like, I was told tummy to tummy. And they're going there. So first of the things that when you talk about attachment is that my colleague likes saying, let the baby face their food. How do we eat? How do all of us eat? We face our food, isn't it? The food. So the baby also has to face their food and be near their food. So we just tell them. So some of the language that we are using, we are changing it. Because yes, it makes sense because you wanted the baby to face the food, but the way it is understood by the mother can be very different. So we talk about baby facing their food and being near their food. So whether it's using a pillow, or it's even just positioning the baby so that the baby is, thank you, Josie. Oh, you'll be my mom, thank you. So Josie is here and she's right there. Okay, your tummy to tummy. Can you see where the tummy is? She's put her baby tummy to tummy. Where is her breast? I'll give you a breast, Josie. Here's your breast. So right where are you? Right there. So we've told them tummy to tummy. So already our attachment is already affected, isn't it? And then the next thing that we tell them is make sure the baby is at the crook of the hand, right there, right? Right there, which is what we've always said, right there. And then, so the baby is at the crook. This is a newborn baby. This is a mother with no confidence. How many, your first baby, you're even wondering where to hold, isn't it? So no confidence. So Josie, yeah, so put there, yeah. So hold in the sea. Try and get that baby. And this baby is flaring. They have all the rooting. They're doing all that. They're kicking you. So what's happening to this mother? Already she's feeling like a failure. So one of the things that we talk about when we talk about attachment, we have to teach them how to hold and attach the baby. And we'll talk about the holds. But when you look at this baby, the thing is for them to get a bit more confidence, and I want you to go and research about the different holds, and we'll talk more about them, but researching, is that this baby, this mother, needs a bit more confidence in being able to attach the baby. So what does that mean? For this position to happen, the nipple above the top lip, opposite the nose. So the nipple to nose. Who knows why that might be important? Nipple to nose. Why? Any reason? Anyone can think. Why do we tell them? The nipple to point at the nose. Okay, so I want us to do a little experiment. I want you to put your thumb right next to your mouth. Okay, so imagine you want to suck your thumb. How would you put your thumb up in your mouth? Where would your thumb need to be for you to suck your thumb? Can you suck when it's there? You need to put it up, right? It needs to go to the roof of your mouth. So when we point the nipple towards the nose, it means that where will the nipple go? It will go up to the baby's palate. For the suckling reflex to happen, for sucking to be activated, the baby needs to feel contact of the nipple on the roof of their mouth. So what happens again, most of us say the baby, oh thank you Josie, the baby's mouth is facing like bullseye. So when we place the nipple and the baby like that, the nipple does not go where it needs to be because it gets up like where you're putting your thumb right here. Are we understanding each other? So we need to point it up, yes, like that, so that that's the approach that the baby does. So that now when the baby closes the mouth like that, we have the nipple where it needs to be, and that's where the nipple is there. The other benefit of that, did you know, fun fact, when a mother gives birth, that first hour, one of the reasons why we want them to put the baby on the breasts, while our baby-friendly hospital initiative, we're talking about babies not being bathed the first 36 hours. Yeah. Why? Any reason? What does the baby smell when they're in utero? Amniotic fluid, isn't it? So if we bathe them and we bathe them with products, what will they smell like? Products, exactly. When a baby is born, the mother's breast emit a smell that smells exactly like amniotic fluid. Fun fact. So when the baby comes to the breast and they smell that activates, their hands are still smelling. You see, how do those babies, they do this. They're looking, what is smelling like this? So that's why we are not bathing them the first time. We want them to be able to smell. So the other reason why you're having that nose, it's getting it as close as possible to the nose, because the baby will smell and that will help their gape reflex. The opening of the mouth, right? So that's number one. So the head needs to be tilted back, right? So this baby's head, you can use this one, yes. This head needs to be tilted back because we are expecting that the baby's mouth will move back onto the front and be able to catch, yes, the breast. So if the baby, again, some of the way we've taught mothers is the head has always been like straight. When we talk about alignment, see, those are the things we've done. The baby's head, nose, everything is aligned. But sometimes what the mother translates, that just meant about positioning. But what the mother translates that is that the baby's head is like that. And so we will not be able to get where we want to be. So the head will be slightly tilted back so that the baby can now move forward and be able to get onto the breasts. Then we have the chin to the breasts. So that means the chin needs to be slightly lower and almost touching before the baby is attached. If the baby is very far, like you can see how Josie's mouth is, if the baby is very far, by the time they attach, we're going to have a very poor latch that's there. And then we look at the chest to breast. So what that means with this baby, thank you, Josie, for being my muse. What it means is that the chest of the baby is like under the breast, kind of. So that now all that will be aligned together. Are we together? Are we together? I hope I haven't lost you. So those principles hold for all holds, and we talk about the different holds. But basically, that helps us to know, you can see the broken line indicates where the baby's mouth is. So depending on the nipple, this nipple here, this mother is able to put the whole nipple inside, isn't it? What about this other mother here? This mother. It's a bit hard, isn't it? For them to put the whole nipple. So we are like, even though the baby might not be able to hold the whole nipple, at least the whole bottom half and at least part of it should be inside the mouth. And sometimes we do one size fits all, and that does not work for most of the breastfeeding or the management of the attachment. Tuko pamoja? All right. Next slide, please. Okay. So what are the results of poor attachment? We've got painful nipples. We've seen babies' nipples shredded, nipples having very, very bad cuts. I once met a mother whose nipple was almost falling off. Literally, it needed a stitch because the baby had done a number of that. And why is that happening? Because the baby's mouth, because the nipple is being held by between the hard palate, between the two gums. So it's not getting up where we want it to be at the roof of the mouth, and that's what's causing that shredding that happens on the nipple. We have damaged nipples. We have engorgement because there's very, very poor milk exchange. The baby is unable to draw milk out of the breast and onto the baby. Baby is unsatisfied, cries a lot. We have these fussy babies. The mother will be telling you the baby keeps crying, keeps coming out and crying because they're actually not getting milk. They feed frequently. How many of you, the mother tells you, the baby has been feeding, my baby feeds for 2 hours, isn't it? So that's telling you there's something wrong. I need to do an assessment. Decreased milk production, because we know milk is supply and demand. So if the milk that is being made is not coming out, we're going to have a problem with the demand. The mother's milk will slowly go down. And then, of course, weight gain is not where it should be. The baby does not add weight. The baby, you're being told my baby feeds all the time, but the baby is not getting the weight that we require. Next slide. So let's talk. Josie, please come back. Yeah. So we're going to talk about the positions. And these positions basically are important. So we have the cradle position. And the cradle position, basically, the baby faces their food. They can still tilt the head back, as you can see. And the mother now holds the breast with a C hold. And the C hold basically is to help attach. But are you seeing how hard this is? For a new mom, right? So, it's a real baby, right? So she's really struggling. So, research has actually shown, and this university, and we'll put all these things up, there was 2 doctors in India who did a study, and they were comparing the cradle position and the cross-cradle position by day 3. And they actually discovered by day 3, the cross-cradle position, which we're going to talk about, which is my favorite for a newborn baby. Actually, the babies had more urine output. They lost less weight because the baby and the mother are both comfortable. So the cross-cradle position, basically, you're able to hold the baby in the opposite hand. The baby, you support the baby's head. Avoid putting your finger, any of your fingers, on the baby's skull. Now, we are very, very good at helping attachment. And so what happens, I will come, and I'll be like, hold the baby like this, and I push. What do you think happens when you hold the the back of the head? Any? One? Okay, let's go back to baby being born in utero. How does the baby come out of the birth canal? How do they resolve? They push their head in, isn't it? And then they come up like that. So why do they do that? When they get to the curve of the mother's, as they're coming out, the mother's body actually holds it and it helps them resolve. So the moment you touch the baby's back of the head, they will rear back. That's even worse if that baby had a vacuum delivery. They're already very, very sore. They've just come out. So the moment I hold their back of the head, they will rear back and will have a problem with attachment. So the moment I do that, and the mother sees you doing that, what will she do? She'll also do it. So you have this baby really struggling with attachment because we are constantly holding their back. So we avoid putting any hand on the back of the baby's head. So the idea is to hold the baby, and one of the ways that I teach the mothers, because we are talking to mothers who do not have experience, so I will tell them, start off here, like where she's supporting the baby's back, right there. Yes, she's supporting the whole of the baby's back. Put the fingers in between the ears, those are so that she can have, I can actually, may I touch you? May I touch you? Kidogo too. So if I'm holding the back of her head, see, she's an adult. I can be able to move her, right? Even without being an adult, I can be able to move her. So you can actually be able to move the baby's head when you put the two fingers in between the ears. And then now I'll tell her, come and bring the baby all the way. And then she will take her breasts, and it doesn't matter what her breast is. It could be even this one. Let's even use this one. That's bigger. Yeah. Yeah, so she can be able to lift her breast, because this breast is heavy, isn't it? And it's a bit down, but she can be able to hold it. And then now do the things we talk. Point to the nose. Are you seeing? She's able to see the baby's nose. Isn't it easier than the cradle position where you're trying to figure out where everything is? So she's pointing to the nose, and then she's seeing how the baby is, exactly. The chin is at the bottom. Are you seeing where the chest is? It's chest to breasts, yeah? The chest is facing the same direction as the breast. Chin to breast, yes, maybe like that. You see where the baby's chest is? It's facing the breast. The way we talked about the chin being near the breast, it's touching, and then its nose. So when the baby opens their mouth, now you put the baby to attach. Then once the baby, yes, attach, exactly, and they attach. Now once the baby is in, she can either continue breastfeeding like that, or now she can take that hand, bring it close, yeah, and continue suckling, and now go into the cradle. So she can move from the cross cradle to the cradle. The cross cradle is fantastic for preemie babies, small babies, newborn babies. It works for every baby and almost guarantees a much better latch than the cradle position. Tuko pamoja? Yeah. We will talk more about it. The cross position for twins. So what it means is that if I have twin babies, I will use the use of pillows. And so I will come and attach one baby underarm, I will attach that one baby like that, right there. And then I will take the other baby. Yes, and I'll take the other baby and attach on the other side, right there. And she can continue breastfeeding for all of them. Cross cradle for them. Do you mind if I take another baby so that it's practical? A bit big, but it will give us the bigger babies. All right. So cross cradle. Yes. Exactly. Yeah. There we go. So she needs some support. This mother would need support. So she would put the first baby and mostly on a pillow, then put the other one, and they cross each other. That's why we talk about the cross cradle. And so the same principles are the same. She attaches that baby, brings the other baby, and she's able to breastfeed both of them. For underarm, she would put this baby there and attach that baby, and put the other baby there and attach that baby. Sawa sawa. We also have the underarm. So when we talk about the underarm, the principles are the same. So this baby, you put a pillow, and you would hold the baby, same as cross cradle, and then now this hand should be supporting the breast. And then she will do the things we've talked about, chin, nose, and all those things, attach the baby, and the baby continues on feeding. This is amazing for preemie babies who are really small, who it's very hard to put in the cross cradle or even in the cradle position. This works very well also for babies who are very sleepy, they are feeding very lazily. This works very well because it's actually able to stimulate them a bit better, and mama is able to see the baby better and support the baby better. We also have the lying down. Josie's laughing because I'm the queen of lying down, but today I'll make her lie down. Okay, here you go. So when we lie down, basically the rule of thumb is that baby needs to be at the same level as the baby. So what I usually encourage them is they can put a little, like fold a blanket, put it under the breasts and the baby so that they're at the kind of like at the same level, so that the baby, especially if the mother has larger breasts, we don't want the breasts covering the baby, right? So she'll put something here that brings her breast and the baby together. And then she'll do the same thing. Same thing, she will attach her baby right there, and she needs a pillow. Can use this baby as a pillow. She needs a larger pillow so that her head is slightly higher. And then, so baby facing, and using that as long as the breast and the baby are at the same level, even if the baby needs to come out, the baby can come out safely. Are we together? Yes, thank you, Josie. Yeah. Yes, oh yes, you lock your shoulder right there. Yes, so she can go that. See how she's locked her shoulder? Over there, and using a pillow, she's able to lock her shoulder. Ideally, and you can see how her body is curved. We talk about the C. The body is curved. If the mother is too straight, her breast will move up, and it can block the baby. So maintaining that C position, locked shoulder, pillow, a bit head higher than her baby, and the breast and the baby together works well, right? We also have, that's not here, we also have a laid back position that's fantastic for C-section moms. And what it would mean is that you're on the chair, maybe she'll scoot down a little. Yes, right there. Exactly. So she scoots down like that and holds the baby more in that position. This position is also very, very good. After a C-section, you can elevate the mother a little and have her hold the baby like that, because most of them are also not able to go on their side immediately after surgery. So this is great. It's also very good for a mother who has a strong letdown, where the milk flows very quickly and the baby is upset. So it's able to, gravity slows down the milk. So that's very good for the baby. So that's also a position that works. Do we have any questions so far? Any question? Tuko pamoja? All right. Let's go. Let's continue on. All right. So when we talk about reflexes for the newborn baby, thank you, Josie. We talk about rooting. Rooting is when you touch the baby's mouth side and you see them going like, they look for this thing, isn't it? So rooting is a reflex, and it's there for around 3 to 4 months. And in this time, it's instinctive. When you touch the side of the baby's mouth, the baby is able to seek the breast. What does that mean? It means that when the baby is starting to feed, the importance of all these things we're talking about being able to touch the baby, being able to position the baby so that they smell you, so that they have all these things stimulated. We also have the sac swallow, you know. So if I put, that's why it's so important if you put your finger as a pediatrician and the mother comes and says, I don't feel that my baby's sucking, it's very weak, wear a glove. Wear a glove, put up your finger up on the baby's roof of the mouth and do like a wiper position. You're able to tell how the baby is actually sucking. I'm sure you do that. But you're able to tell, the mother is saying, it's very painful, I can't seem to get, and you want to see, how is this baby sucking? And that also helps you. Sometimes I teach the moms, and I'll tell them, wear this glove, can you put the baby's mouth, put it right at the edge, and put it up. Then they feel, oh, that's where the breast needs to be. You know, teaching with hearing, people learn differently. And they're able to feel, what are you feeling when you just put it here? The baby is unable to suck. So that suck swallow, when the baby feels the force or something at the back, amazingly, the nasal cavities close a little, and the baby, to allow the baby to swallow, and then they continue breathing as they pull. And the rhythmic that happens, this particular reflex allows the baby to even, you can be lying down. And I know some people are told, no, don't lie down, they can choke. They really can't. Because of the suck swallow reflex, they are able to be reclining and continue on feeding. And that theory of lying down and not breastfeeding, oh, I'm looking for a baby, doesn't hold water. Why? If I'm holding my baby like this, right? Because I've met moms who are told, I was told lying down is dangerous. So I'm putting my baby like this. If I lie down, where is the baby? It's exactly the same position, isn't it? If I lie down, it's the same position. So it really doesn't matter. The baby can be reclining, and they're actually reclining when they're feeding, even when I'm holding them, or if we are lying down, it's the same. So maternal comfort is very important. The tongue thrust reflex, when we touch the lips, what does the baby do? Right? That's the tongue thrust reflex. And basically, it assists in feeding, because as they move the tongue forward, it's able to hold the breast and be able to draw milk out of the breast. But it also pushes out any solid food that is put there. Babies will lose the tongue thrust reflex from around 5 months, 5 to 6 months. And those are some of the indicators when we start talking about readiness, solid readiness, being able to eat solids. If this baby is coming and still has not lost the tongue thrust reflex, and you see this a lot in preemie babies, they might be 6 months, but they still haven't lost it, especially if they were really preemie, then you'll find that they still have that reflex, and they might not be ready for solids. And then the gag reflex, when you place something at the back of the mouth, protects against choking, and it reduces triggering at the back at around 6 months. But at 6 months, it will still be there, but that's only when a solid is put there. So all these reflexes are there to protect and enhance breastfeeding the first 6 months. And by then the baby learns and they continue on breastfeeding. After 6 months, for most babies after 4 or 5 months, breastfeeding now is something that it's a skill they've already learned. The first few months, it is supported by these reflexes, right? Okay, next slide. Want to watch a little video. What happens to our babies when they are preemies? How do we protect our supply? And that means we need to hand express. So we'll watch a little video and then move on from there. Okay. She's saying, let's give us 1 minute. So basically, when we express, first of all, a lot of us will have mothers go and the mother might not have milk. We need to be careful how we as they're getting ready. Breast milk, colostrum is very thick, right? And when it's very, very thick at the beginning, and so how we express matters. When we look at those ducts, they are quite narrow, isn't it? They are quite narrow. Colostrum is very thick. So when we ask the mothers to bring their breast pumps to the hospital, or when the baby has been born and the baby cannot breastfeed for any reason, they're premature, they are sick, any of those, and we tell the mother, get the breast pump to pump.
Recording in progress.
Most times, it's not going to work because the milk is very thick. So what actually works is hand expression, because hand expression is able to stimulate the milk and be able to draw milk out of the breast. Breast pumps most times will work when the mature milk has come in, as my colleague has mentioned, towards the end of the first week, because that milk is not as thick as colostrum. So for colostrum, we talk about hand expression, and hand expression is usually able to draw out the milk that is there. So it's important for us to demonstrate hand expression to the baby. As you've seen, it's important for us to demonstrate it. Sometimes you might not have time. So the global health media, they have these videos on YouTube. So find them. You can forward to the mothers, and they have for health workers and for mothers. So you can actually forward to them if they need to see how to express. Sometimes you might not have the time. And that helps. And that marmet technique is really great at being able to remove milk. Can you see why the pump wouldn't work at the beginning? Yeah, the milk is far away, it's deep into the breast tissue, it is thick, so the marmet technique is able to bring out the milk, the massaging, the relaxing, and supporting the baby, skin to skin, will help the mother produce this milk. Okay, so we want to do what we call breastfeeding observation. This is now a mother has come to you, and is saying, baby is not thriving. Oh, I'm really struggling with breastfeeding. How do I do a breastfeeding observation? And the acronym is actually BREAST, as you can see. And so we have to look at body position. So we are looking at the position of the mother. Is she doing tummy to tummy? You know, all those things that we've talked about. How is she? Is she looking comfortable as she's holding her baby? Where is the baby? Is the baby down here? Is the baby's head, is the baby facing up with head turned to the side? Or are we looking at the things we talked about when we look at how a latch appears? So the body position of both the baby and the mother is important, and we need to make sure that it is correct. Then we're looking at responses. Josie, may I have you back? You can be my mother, yeah. We're looking at responses. Yeah, the response of both the baby and the mother. So how is the mother looking? Yeah, look at that. So she's put the baby on the breast. Yeah, she's, even in those 2 minutes, that's how she's behaving. What does that tell you? There's something going on, eh? There's no bonding. There's something not quite there. So that could be, the issue is not with the baby. The issue now could be with the mother. So you inquire first, how is it going? How is it at home? Do you have support? How are you feeling? Yeah, so that could be either you can deal with that or you can refer to a psychologist. Sometimes those are markers of postpartum depression. So what are we looking at? So yeah, we're looking at the baby. Yeah, we're seeing the baby. How's the baby responding? Kicking, fighting, fussy, coming out, in and out. What does that tell you? Yeah? Fussy feeding? Could be a poor latch, isn't it? Could be a strong letdown. The mother might have a very strong letdown. Once the milk hits the baby's mouth, the baby's choking and sputtering and doing all those things, isn't it? So what's the response of the baby? And that now tells you, okay, what is it? If the baby is sputtering and milk is flowing out, we know that's a strong letdown. So what do you think we can tell the mother with a strong letdown? express a little before, yeah, and just a little, not too much. Because if they express and empty, what happens to the brain? Let's make more. And so the supply now, the letdown becomes even stronger. So it's basically expressing just a little to reduce the flow. What other thing can we tell them? Huh? Recline, yes, the laid back movement, so that the milk gravity can reduce. What's something else that we can tell them? We can also use the opposite hand, this hand, to push back. When she feels the letdown coming, she can push tightly back to her chest. That can also kind of slow it down, right? So all these are issues, but also improving the latch. Sometimes the latch is shallow, and so the milk is pulling much more than it would. If the baby has a deeper latch, then they're able to handle the flow, right? We look at emotional bonding. That's also goes with the response. How is the mother looking? How is the baby looking? Is the baby looking at the mother? Is the mother looking at the baby? Then we look at an anatomy. Whose anatomy are we looking at? Both, eh? So for the mother, we are looking, how is the breast? Is it a deep? Is it a inverted nipple? Is it a flat nipple? Is it a very big nipple? I once met a mom with twin nipples together. Is it a very big breast? Is it a small breast? All these things matter, so that you're able now to guide the mother. If I'm having a very small nipple, then I might need to really bring the baby closer. I might need the baby to hold the whole areola so that the nipple touches the roof of the mouth. If it's flat nipples, the same, yeah? What happens to a mother who has flat nipples or inverted nipples? What do we usually do? Syringe, eh? Uh-huh. So the syringe, how do you think that goes? It's painful? Does it quite work? It works, eh? Sometimes. So, when we talk about the golden hour, attachment to the baby whenever possible within the first golden hour, babies are able to attach for themselves. And I want you to just go look again at global health and look at attachment of the baby in the first hour. And we want to start encouraging that the baby actually doing the breast crawl, where you put the babies on the mother's tummy, uninterrupted 1 hour, and the baby will actually get to the breast and attach themselves. But when we talk about attachment of uninverted nipples, we are thinking of the nipple. But do we nipple feed or breastfeed? We breastfeed, isn't it? So we can actually do what we call a breast sandwich, which means, first of all, making sure that the entire area is softened. A lot of times, we meet many mothers, we don't use syringes. We do have a tool, I'll show you in a minute. But basically, if you soften this whole area, and then you do the cross cradle, the one we've talked about, and then have the mother's sandwich like that. See, like that? Have I formed a nipple? So that now the baby is able to come and hold most of the bottom half and the nipple. And they're actually able now to attach, right? So that's good that we can do. All right. So anatomy of the baby. How does that matter? Yes. In case of tongue restrictions, isn't it? Tongue tie, lip tie. Really encouraging most of you pediatricians to do. We are really suffering. We are struggling. We need to encourage you to endeni masomo. Mtusaidia hawa watoto wako na restrictions. The babies with restrictions, it can be quite a problem because sometimes that's the issue. How do we support this mother? Either to have the restrictions released or having this baby be able to continue. How is the sucking going? How are we terminating the feed? Who is terminating the feed? Is it the mother? The baby is not adding weight, and then we hear, baby is not adding weight. Then you ask the mother, you need to ask that question. How long does a baby feed? The mother will tell you, oh, I feed 10 minutes here, and then I remove, and I put the 10 minutes. So it's the mother terminating the feed. Ideally, it's the baby who should terminate the feed. All right. This second baby, what are they doing? They're on the breast, very well attached, right? But it's a little flatter, right? Just very little movement. So this second baby, this first baby is actually drinking, right? You could see the action. It's one suck per swallow, and they are actually going. The second baby is on the breast, well attached. The pause is very long. They're basically drinking, but very little. So babies do what we call nutritive suckling, which is what the first baby is doing. There's gold milk exchange. And then there's non-nutritive suckling, where basically the baby is on the breast, but they are not actually drinking. So what do we do, especially this baby who's come? Mother seemingly has enough milk, but there is not good milk exchange. Then we do now what we call breast compressions, so that now we can force this baby to drink. So the next baby's video, sorry, it's not showing. Okay, so basically, Josie, the video has refused to play, so please come again. And basically, I was looking for the other breast, the big one. Yes, yes. So basically, what you would improve to that mother whose baby is doing a lot of that non-nutritive, they're taking long at the breast, mother is thinking they're taking 2 hours, then we can help with breast compression, which basically means that she will hold the breast and allow the baby to eat. When the baby slows down, she compresses the breast like that, like basically, yeah, compresses very softly, compresses, and continues like that. So the baby is drinking, but because she's compressing, it's almost like hand expressing. So hand expressing is done. So as she's doing that, she's stimulating the milk at the back to flow onto the areola. And because the baby is well attached, the milk will actually flow. So in that feed, the baby is able to get more milk out than if they were just doing the non-nutritive suckling. It's okay for the babies to do non-nutritive suckling, but it needs to be not the whole feed. They should have fed and that good drinking. But now for that maybe preemie baby or very seemingly lazy baby at the breast, then hand compressions are important. So it's push, relax, and it's very gentle because you don't want to remove the good latch. You don't want to dislodge the baby. So you're basically just compressing a little, yeah. Especially when you see the baby slowing down, compress, and breast compressions would work. Are we together? Thank you. Next slide. So what does effective milk exchange look like? Audible sounds of swallowing. You know that swallowing? This baby will begin with the first suck to stimulate the letdown, and then they get into a rhythm. You know, suck, swallow, suck, swallow, suck, swallow, and then they pause. If again the baby is just feeding, 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 and not pausing, it means there's no swallowing going on. Remember we said if the baby is swallowing, the nasal cavity closes a little to allow the swallowing, and then the baby continues on breathing. So if there's no pause, it means that the baby is actually not breastfeeding. I mean, there's no milk exchange happening. So we need to see that pausing happening. Then it becomes slower as the feeding continues. And then basically we see one suck per swallow, suckle. And then there's no stroking, there's no milk flowing out of, you know, the sides of the mouth. There's no friction, there's no tongue, you're not hearing mwah, 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 you know, and all those things. So, and if you hear those, then you need to look again at anatomy, both for the baby, because we know some babies with tongue ties. I know mothers have been told you're not latching the baby properly, but sometimes the baby has restrictions, and that's causing the baby not to have a good latch. Next slide. So, as I'm about to finish, these are some of the things that you will see generally in your practice. Sore nipples, flat inverted nipples, and for inverted nipples, you've seen this? It's old. It's 200 bob. It's in the baby shops. Isn't this much better than the syringe? Yes. So you can see. So you put it on the breast and you pull. And even for this one, right? And so it's able to pull. The mother can do for herself. It's less painful. So we have this tool that can be used. So that really works for those babies. So you can pull and have the mother use it and go and tell her to purchase one, and then she sees. And this can even be done, especially for us who see mothers antenatally. Observe the breast, so that this is something she already has by the time she's coming to hospital. Sore nipples. So those are the breastfeeding aids we are talking around. We're looking at tongue ties, because they will definitely have cracked nipples, and being able to correct that. Low milk supply. So we look at the baby breast brain cycle. Is this mother actually putting the baby on the breast on demand? Is she, guiding? There are all these books nowadays that tell you to put your baby on a schedule. Because once the breast doesn't work like that. Schedules don't work with breastfeeding. So ask these questions, because sometimes that's what they've read a book that has told them baby feeds every 3 hours. So they're actually not feeding the baby the way the baby basically gives that biofeedback. Babies are like us. They don't feed on the clock. And when we say feed every 2 to 3 hours, sometimes that can be very confusing for a sleepy baby. Or when the baby comes and is doing what we call clusters of feed. Since I woke up, I ate something, then I'll take a fruit, then we eat all the time, don't we? So how do we expect our babies to feed like on the clock? Babies will do major feeds, then they'll do cluster feeds, small feeds through the day. And cluster feeding is important for supply. So looking at that, because it helps that consistent and frequent removal of milk. Night feeding. Prolactin is higher at night. If the baby, in Nairobi, I don't know if you're seeing it, but in Nairobi now there's this thing called night nurses. Night nurses come, they are with you through the night, and the baby is just basically given to the nurse, and mama sleeps. And then in the morning, the mother continues breastfeeding. What do you think happens to supply? It will go. So sometimes they're asking you, they're like, I have a night nurse. So basically, if you don't breastfeed at night, or even when the baby starts sleeping through the night, we encourage the mother, please wake up the baby even once, or express the milk. Prolactin is produced at night. If you do not breastfeed at night, the supply will go away. So basically, when they go back to work, did you know that you have 1 hour protected time in your workplace? Every workplace should have a lactation space set aside. If this mother goes back to work and is not removing milk through the 8 hours she's at work, her supply will go down. So sometimes when they're there at 3-4 months and she's saying the milk is down, is to ask her, are you expressing at work? Every 2 to 3 hours, kind of aping what the baby does at home to keep the breast baby brain cycle going. So you review positioning and attachment, and then also talking to them about how we enabling and supporting that mother-baby diet in terms of the home setup and all those things. Fussy and gassy baby. So again, we review attachment. Most times, potential tongue tie. We do know that babies who have tongue ties or restrictions tend to really fuss at the breast because they really struggle with the tongue movement. Now we know that some babies, through to birth injuries, maybe those vacuum delivery, forceps delivery, they can have very tight shoulders. So incorporating massage, and now we have adjustments, people who help the baby relax more, can improve baby's latch. We review milk transfer. How is the milk actually being transferred? Does the mother have a strong letdown, or is it very, very low? So all those things would influence why the baby is fussy at the breast. And then we do know intolerances to food. If the baby has allergies and they are gassy and they are colicky and all that, then we can review the mother's diet, keeping a food diary to see probably the baby has an intolerance to dairy and it's passing on to mothers. By the way, this is now something that we know is there. But what we encourage the mother not to restrict their diet, because now I'm seeing mothers really restricting their diets, but also improve their own gut. So eating better so that the food does not enter the circulatory system. Their own gut, the mother's gut is the one that's not okay. And it's allowing food to cross the barrier into the bloodstream, and that's what's causing issues to the baby. So the mother can go on probiotics, eat better, improve their own diet, and usually, even if she eats anything, it doesn't affect the baby. So you actually review both. Engorgement and mastitis. This is basically removal. So one of the reasons why mastitis is really, really a lot in today's world is all these Instagram pages where moms post a whole fridge full of milk. And so, again, we are guilty of telling our mothers to pump from day one. That's a problem. It's breastfeed. The moment the mother starts to breastfeed and pump and she's removing way more milk, the brain can go on to overdrive. And then now we have overproduction of milk. And then when we have overproduction, then this mother is prone to engorgement and basically having a lot of that mastitis growing. Also, we are also very good at prescribing motilium yeah, I'm seeing some smiles. Motilium at day 1 and day 2. Actually, the directives for motilium, it should be at day 10, when a mother has proven that she cannot make milk. Because what does motilium do? Brings the milk, but we said colostrum is very thick. So we are bringing a lot of milk, and the ducts are small. So we are creating a traffic jam. And so we find these mothers, you even have to give them oxytocin shots, syntocinon, so that the milk can actually start flowing. It's refused because there's a traffic jam. So also really, really protecting that enabling environment of mother-baby. Attach the baby to the breast. It's the baby. If the baby is not there, you express. Let the milk start to come naturally. Then by around the end of the first week, if really milk is not coming, then we can use some of these aids that we have. Motilium is great, but we are misusing it by prescribing for every new mother. Even, I see them. I've visited moms and I'm seeing them being given at the 2nd hour after birth, when they're being given the painkillers. So we are creating issues with engorgement and even mastitis within the first week, because the mother has not, even the baby is still learning how to breastfeed. So if the milk is too much, we're going to have a problem. So expressing frequency, not expressing too much. We actually encourage our mothers to start expressing from around week 3. From week 1, 2 is more expressing for comfort. Let's say the baby has fed on one and the other one feels full. I can hand express a little. Once I feel comfortable, I stop. Let the brain first regularize itself. Let the milk, the colostrum pass. Because if colostrum is thick and the milk is too much, we're going to have a problem with engorgement. Avoid, so we also have I have seen mothers being massaged. Yeah? So we've got engorgement. And you're there with deep tissue, massage, right? What do you think is happening inside the breast? We cause inflammation. And so sometimes how we deal with engorgement is the leading cause of mastitis. It's actually not because that mother was meant to have mastitis. It's because we've created inflammation in the breast. If those bacteria in the breast, we've spread it further, because we've massaged it. So the protocol for mastitis now is basically slowly massage, just gently, express or feed the baby is what's preferred. Feed the baby, and then after feeding the baby, we put a cold compress. What are we doing with the hot water? Yeah, so what does hot water do? Even stimulates more supply. And we are trying to slow it down so that the breast can heal. So we reduce some of those things. So we are not doing excessive pressure or heat. We're actually doing cold. So gentle massage, feed the baby, and then apply a cold compress. She can also use cabbage leaves if she's at home. She takes a cabbage leaf, a whole leaf of cabbage, put it in the fridge, and then take that leaf, scrape it a little, to allow, so cabbage has an enzyme that helps to break down inflammation, that helps with inflammation. So it's cold, it has that enzyme, put it in the breast after the feed. And that will really cool down the breast and reduce engorgement. For a mother with very, very big engorgement, you can also encourage, the engorgement is a lot. And we grade engorgement kind of like touch your forehead. So if the breast feels like that, that one is a lot of engorgement. So that one we use a lot of cold. She can sleep on her back to allow the body to reabsorb some of the fluids, and using a lot of cabbage to reduce. If it feels more like your nose, then it's a bit softer. That one she can use just mild massage. And the massage is really light. Sometimes even using a comb. You know what's that little comb? The comb for the jolly comb. And she just massages across her breast like that. We also have a breast massager. If you come to our stand, you can see it. And basically massage just very gently, not to cause inflammation inside the breast, and then she breastfeeds the baby. So it depends on which it is. And then after that, put a cold compress. So we are going into more cold than warm. And then slow weight gain. So we review the milk exchange. How is the baby? Is the baby actually getting milk? What's the feeding habits? Is the mother terminating the feed? Can we, before we go to formula feeds, can we see if there's really a bit of milk exchange, very sleepy babies? Can we also, you've seen the babies being fed. That's why we're doing this assessment. They're being fed with all these clothes, like 5 different layers of clothes. But if you reduced all those layers, the baby might feed better. Or now, if this baby is really struggling, can we first go to expression of milk? Hand express, remove some milk, and have the baby fed with a cup. We really discourage bottles because they do cause, a lot of times we've talked about nipple confusion, but now we are talking about preference. The babies are not stupid. They're very clever. They're just human. They prefer the easy way out, which is the bottle. So we cup feed the baby to protect breastfeeding so that we can encourage them to breastfeed for as long as possible. Yeah, and I think with that, I am done. Yes, I am? Yes, you are. Yes, I am. Yes. So thank you so much for listening to us.